Hi, everyone. I am Dr. Joanne Keefe, a family nurse practitioner and an epidemiologist. I teach the epidemiology and biostatistics course at Frontier Nursing University. I have the honor of providing this quick look at precautions in the clinical setting around COVID-19. I do want to point out that I'm creating this video on March 22nd of 2020, and we're dealing with a novel virus, brand new to us and has many unknown aspects. Some of the material I'll be discussing is likely to change. I'm placing links and articles in this presentation as a way to provide you with places to investigate, learn, and keep up with changes as they occur. I've tried to stick with CDC resources predominantly as their evidence-based and a most reliable source. The purpose of this presentation is to provide you with the knowledge and considerations designed to empower you to make good decisions around keeping yourself and others safe during this COVID-19 pandemic. I'll provide a refresher on concepts related to disease transmission, discuss the most recent CDC recommendations, and provide additional considerations for decreasing the spread of the virus. I know that we're all healthcare providers who have dealt with infection control on some level or another. This is just a refresher to the extent that you need it. And I also know that I cannot teach to every situation that you're going to encounter. I hope when you're armed with the information presented here, you'll be able to apply that using critical thinking and choose the best course of action for your particular experience. Let's renew some of the basic concepts first. This is the simple model of disease transmission. It's called the Epidemiologic Triad. If nothing else, you can kind of keep this in mind. Sometimes the environment is drawn as a triangle that the agent and host sit on, rest on, showing that the environment actually is what supports the agent and the host getting together. It's kind of different ways to think about this. If the host and agent don't get together, there's no infection. So this is essentially where we need to think about how to manipulate the factors that go into creating disease and think about how we can stop infection. This model that I posted on here on this slide elaborates on things to think about in terms of each aspect of this. So with the host, we can think of so many things, and with the agent things, so we can think of ways that we can attack each of the areas there. As nurses, we tend to think about our patients in the bigger picture, in the context of things. So I think that using these extra considerations outside of the three pieces of host, environment, and agent are just building on our way that we think as nurses anyway. The COVID-19 interventions at this point that we have are host level interventions. So we're talking about keeping the host healthy, increasing the host defenses, and protecting then the portal of exit and the portal of entry, and trying to keep the host as healthy as possible and away from the virus in that way. We are working on, not we, but as a world, we are working on ways of controlling or eliminating the agent with antivirals and vaccines, et cetera, but we are not there yet. So we're actually focusing right now on the host level. I want to zoom in just a little bit on COVID-specific issues, some important points about the virus that contribute to how we decrease the spread and how we're going to prioritize our action. Important to note that the virus can be shed in asymptomatic patients, and then it's looking more severe in high-risk groups, people of older age, they're saying over 60, chronic medical conditions such as diabetes, COPD, cardiovascular disease, hypertension, and cancer. And the reason for this, why it's more severe in these groups is one is a decreased immune system. And then the other thing is that this particular virus attacks the respiratory and cardiovascular system as a priority. And so people with a weakness in that area are having especially severe courses of illness or are set up for it. So APIC, the Association for Professionals in Infection Control and Epidemiology, has a wonderful website that I want to share here as information for you. They put together this poster here, which is a beautiful poster of the chain of infection. This is just another model that we use in looking at disease transmission. It breaks down the process in more detail, kind of spreads it out a little bit, and may help thinking about ways that we can interrupt even one piece of the chain, which will stop the infection. For example, here between the mode of transmission and the portal of entry, if we want to block that, is where we have our PPE, where we are keeping the virus from entering the portal of entry and infecting the next person. So if we break this chain of infection in any of the links, the infection does not occur. I want to go back and talk about some of the terminology and recommendations for protections. These are areas of importance, particularly around COVID-19. A little review on direct and indirect transmission. So with direct transmission, the easy way to think about it is that the person needs to be in the room with you. With direct transmission, there are two main types. One is direct contact and one is droplet spread. Direct contact is exactly what it sounds like, touching another person or their body fluids. At this point, the virus has been found in stool. That was noted on March 7th, but it's unclear at this time if blood, vomit, and urine contain the virus. So stay tuned for that. However, touching another person where they have been coughing into their sleeve, say, or their arm, and then you touch that, you're picking up the virus, that kind of thing. So touching another person, direct contact. The next level or the next thing under direct transmission is droplet spread. And with droplet spread, we're talking about sputum that somebody sprays out into the room. That droplet is a large particle, and in terms of it being contagious, that large particle is sprayed. What they're saying is probably about 3 feet, and then it drops the ground, although the safe distance to stay is 6 feet away from a person, but that particle actually lands on your mouth, your nose, or your eyes, and then you get the virus that way. So it's a big particle that doesn't suspend in the air. It just has a trajectory and then drops to the ground. This is different than an indirect, where a person has left the room. This is the next transmission. These are much more hard to think about. So with airborne, you have an aerosolized sputum, which is actually floating in the air. And we're going to get into a little bit more about droplet and airborne in just a minute. And then vehicle-borne is talking about more like surfaces and fomites. They just found recently that this virus can live up to 4 hours on copper, to 24 hours on cardboard, and 2 to 3 days on plastic and stainless steel. Of note, they don't feel like there are any vectors, so no flies, mosquitoes, etc. for transmission. Let's zoom in just a little bit more on droplet and airborne. So once again, with droplet, it's direct transmission. It's a large particle that drops after short distances. They're thinking about 3 feet. 3 to 6 is sort of a danger zone as well, but definitely 3 feet. They know that it will go that far. This is when you person is just sneezing, coughing, or talking, and sputum is leaving them and getting on to the next person. As opposed to airborne, which is indirect transmission, right? It can stay in the air even after the person is out of the room. It's a spray with smaller particles, and that's less than 5 microns in size. So that's really a differentiation between droplet and airborne. It's going to be carried in the air, and aerosolized COVID-19 particles have been found in the air to be living in the air for up to 3 hours. And aerosolizing procedures include CPR, ventilators use including intubation, extubation, and suctioning time, and also nebulizers, use of nebulizers. So the recommendations here are that don't get the virus in your nose, eyes, or mouth, which is really simple, but not easy to accomplish, right? This is when the CDC recommendations start to make more sense. So when we're talking about direct transmission and direct contact, where we have to touch another person to get this, this is where they're recommending don't shake hands, don't hug, and wash your hands often. With droplet spread, you want to stay at least 3 feet from the person. 6 is ideal. Avoid close contact with others. Use distance as much as you can. This is when the recommendations are if you're sick, stay home. Cover your cough, wash your hands, etc. If at this point, as a healthcare provider, you have PPE available, paper mask will work, a paper medical mask will work for this. And then also recommended is eye protection, gloves, and a gown. For indirect or airborne, well, with indirect where the person has left the room, things to consider. Airborne is when, remember, you're aerosolizing things. If the PPE is required, use an N95 mask instead of the paper mask, and then eye protection, gloves, and gown. Consider in a clinic or in any situation that you can using an MDI instead of a nebulizer. There's actually been a study that they're equally good, and that study is listed here. And then for vehicle-borne with fomites such as surfaces, clean and disinfect everything that we touch and contaminated surfaces. And remember, it's not just our hands that are touching things, but when we set down our phones, our laptops, etc., think about contaminated surfaces and then what we also touch that is contaminated, and then we bring the virus then to our own eyes, nose, and mouth. Now we want to move on to the application a little bit more and other considerations about infection control with COVID. The first thing is to talk about proper PPE. N95 masks should ideally have some training that came with them. They should have been fitted, you know which N95 mask is best for your particular face, and learning how to check the seal on your N95 mask. So definitely important whenever you put on an N95 mask to check the seal, number one thing. General rule of thumb, if the face mask is wet or soiled, throw it out. If you touch the outside of the mask or your eye protection, wash your hands. That is the contaminated area of the mask, and you want to make sure you wash your hands anytime you touch that. I'm going to go into a little bit more about reusing masks. We're at now a critical shortage of PPE, and I'm going to go into that in a little bit more detail and offer some resources for you to learn how to reuse masks. If you have facial hair or you haven't been fitted for a mask and you have access to a PAPR, the powered air purifying respirator, use that ideally, but that must be cleaned after each use, should be. And then of the utmost important is learning how to don and doff your PPE properly. I don't know if people are still using the term don and doff, but it's putting on and taking off. The most important piece of that is how you take it off. I put a website here which talks about proper sequence of how you take off your PPE. And taking off PPE is actually a huge source of contamination. So we've protected ourselves from the immediate situation, and then we go to take off the PPE, and we end up contaminating ourselves in that process. We found that when we were working with Ebola, the Ebola outbreak that was going on, that we really have a need to work on doffing our PPE. And actually, I found a study that talked about 36% of the contamination for healthcare workers was done in the doffing procedure. So super important to kind of learn that again and to be mindful of how you're doing that. That's a really important piece of this, including having a buddy watch you and say, yes or no, that was not a good way to do it, or I want you to kind of beef up this area, and do that for each other. Other things to think about: who is assigned to tasks? Remember that some workers that we have here are at high risk of severe illness, and to have them do something beside being the most high risk of areas. And if you are a person who's the highest risk and you could be doing something else to kind of get away from whatever you're doing, if at all possible, that could put you at increased risk of getting the disease. Thinking about how many folks are needed for something, in my experience, things like codes, where we have an increased aerosolized sputum situation and the room is packed full of everybody watching the code and participating on some level. Sometimes it's just observation. So I know that's an extreme situation, but kind of thinking about who needs to be in the room for whatever procedure or situation that's going on. Equipment, especially thinking about shared equipment such as blood pressure cuffs and temperature probes and O2 sat monitors at check-in or at any point need to be cleaned between patients, and think about the place where the patient is sitting, the last patient coughed, touched, whatever. So thinking about shared equipment and shared space. Consider your cleaning crew or whoever is doing your cleaning. If you have an aerosolized situation, somebody just had a nebulizer in one of your exam rooms, or somebody just came off a ventilator and they're doing a terminal clean, the cleaning crew also needs PPE that's appropriate to the situation, or give it some time. Wait 3 hours for that area to be cleaned if you have that kind of thing, that kind of option. So just kind of be mindful about all the people that we work with and the roles that they play and how they're exposed to different things. Visitors and family may need to be limited in this situation. The CDC has left it up to be a case-by-case basis and left it up to the facility. Consider that there's a shortage of PPE, and even though the patient's family is at high risk if they're COVID positive, the family's at high risk of getting COVID. At this point, we are shifting to protecting the healthcare workers, and so that we can continue to take care of the greater number of patients, save your PPE for healthcare workers, and so really consider that. At the very least, teach your visitors about hand washing, infection control, covering the cough, etc., and what areas that they can be allowed in, because then now they're high risk, maybe incubating the virus and are shedding at this point. So we need to make sure that we keep them also contained in our environment. Thinking about outpatient clinics and waiting rooms, some of the recommendations by CDC are to just reschedule non-urgent visits. If you have a high-risk patient and you need to follow them, call them up and ensure that they have access to medication and that they are using it, and that they know how to get a hold of you if they have symptoms, and not to come into the clinic and then you deal with that as you go. If you have symptomatic patients that you're seeing in your clinic, ask them to call or put a sign outside to call before they leave home or to call before they come into the clinic so that the staff can receive them using appropriate PPE. Also consider telehealth in this situation. In terms of waiting rooms, I think that we need to move away from the waiting room mentality right now in the waiting room situation. If you are working in a place that does have a waiting room, to at least have signage as they're coming into the waiting room about hand hygiene and respiratory hygiene and cough etiquette, and provide the supplies that you can to ensure that they can do that, such as tissues and trash cans and hand sanitizer. Once again, we're moving away from giving patients masks. However, if you have face masks, the CDC at one point was recommending that we make them available for patients with respiratory syndromes. As I said, we're moving away from that at this point. Try to keep the patients 6 feet apart. Use that distance in order to kind of decrease the spread, the droplet spread that we're thinking about. Consider car triage, car testing, or have them call in, lock the clinic down, ask them to give a call to the front desk, and when it's their time to come in, the waiting room is their car, each person in their own car. You go out and you either text them that they can come in and you let them in, and one at a time entry into the clinic to try to decrease the spread of people just sitting around and just coughing with each other. And then you have people who are well also mingling with that. It's kind of something that we need to move away from. The last thing I want to talk about is healthcare workers. Avoid being typhoid Mary in this situation. Healthcare workers, of course, are at super high risk with this, of getting this virus. And so if you're symptomatic and they're calling that a fever of greater than 100 degrees Fahrenheit, they're actually including subjective fever in this definition, and or if you have a cough, short of breath, sore throat, stay home. Don't go to work. Call your appropriate contact at work for next steps. There are things that they're going to want to do with you. And it may be asking you to come in, depending on how short staffing is. But call and get next steps from the place that you work. There are, in case of exposure, there are guidelines from the CDC here, and it talks about if you were exposed to somebody who's positive and it was this sort of situation, you can still stay at work. We're just going to check your temperature twice a day, versus who needs to stay home and make sure that they're negative. Okay, let's talk about PPE shortage issues. This is a real deal. So we are running out of masks, including N95 masks, paper masks, and then, of course, gowns and eye protection. So we need to now change to a harm reduction mindset. How can we reduce the harm done in light of a shortage of supplies? As I said, we're shifting the focus on from taking care of the patients and providing them with all the PPE and moving to taking care of the healthcare worker and trying to protect and preserve our healthcare worker force for as long as possible. One of the things I do want to bring up, because this seems to be a huge confusion about why doesn't it benefit for patients to be wearing masks? Yes, proper use of masks on patients actually does help. When we're talking about the chain of infection, it actually breaks the chain at the portal of exit or decreases the amount of droplets that are put out into the environment. But at this point, as I said, we are decreasing the use of PPE for patients. Of note, reports of panicked patients taking masks, gloves, hand sanitizer, toilet paper, and in the clinic that I work in, one of them, they're taking nebulizers as well. So to secure those things, make sure you have them for your workforce. And these are patients who are still in an individual health mindset, and they're panicked and they're thinking about their own selves and their own families. We need to move to a more public health. How do we help the most people through this? And that is by taking care of our workforce. There are specific guidance from the CDC that talks about 4 different areas and what to do as these things kind of go away. So here's the website, and you can see that once you go there, it's broken down for eye protection, mask, gown, and N95 masks. And then under each of those categories, it goes under 3 strategy plans, with a conventional, which is not the situation that we are in now. Contingency is when we start running out, and crisis is when we are really running out, and when we have to make decisions about what to do when we have no PPE. So there is information there about that from the CDC. I would say that some of us are still in contingency mode, but overall we're moving to the crisis mode of this. So take a look at contingency and at crisis if you have any questions about what you can reuse and how you can make things last. In crisis, they're saying you may use masks after expiration date. So if you have something that's expired, make sure that you're good with the rubber and things like that are on it, but still feel free to use it, definitely. And then there are ideas for reuse of masks between patients. Caution, once again, once we're reusing masks, there's a part of the mask that is contaminated. Super careful with that. We are increasing our chance of getting infected by using them, but once again, it's harm reduction. We have more problem if we don't have a mask at all than if we have one that we're reusing. But just to be very, very mindful of that. There's also at this website right here, recommendations for reuse of masks, when and when not to reuse them, and how to store them, etc. A word on fabric masks. There's an increased risk of infection using a fabric mask over a medical mask. Is it potentially better than no mask at all? Highly likely. It's definitely plausible. However, in this study and there are very few studies regarding fabric masks, but they didn't compare this to no mask at all. So as one might think, of course, the medical masks are better than a fabric mask. We don't know compared to no mask at all. I think that what we need to keep in mind if we're using fabric masks, if we get to that point, and if our patients are using fabric masks, is that not to rely on them over the basic principles of infection control. Social distancing is still more effective. Just because you have a woven mask on or a crocheted mask on, it does not mean that you can go out and then mingle in public. Still to maintain social distancing, good hand washing, and it probably could decrease the amount of droplets that's put out there, but it's really not going to be replacing any of the other things that we've been doing. That's it for now. So I hope this brief overview proves helpful to you, empowers you to make safe decisions during the pandemic. Thank you for your time and attention. My email is here if you have questions. I hope that everyone stays safe, and now that you have some good links, keep up with this and do the best that you can with what we have. I appreciate your time and attention, everyone.